I'll be quick, I promise. Yeah, yes. So yesterday on cancer research, what's happening yesterday, I gave a speech which is on the qualitative study. So this is just a subset of my main study, which is on the economic impact of cancer care in tribal families in Meghalaya, India. So I think most of you have heard about India, maybe the other part of India, but this is the another region of India. I'm going to show you a map later. Okay. So as we all know, this is cancer is a top cause of mortality globally, and we have seen that a 45% rise in a global cancer death from 2008 to 2030. And also we have seen that mortality rates are disproportionately higher in the less developed nations, and 1.5 million cases and 0.74 million deaths, which has happened all over the world. And the higher rates is in the Northeast region in India. It is also known as the cancer hub in India. So I'll be talking about my study area, which is in Meghalaya. It is Northeast region. So in this region, we have a diverse culture. Diverse culture, as in like the food, what we eat, the culture, what we practice, it is totally different from the remaining parts of India. So here we have seen that the high incidence due to tobacco and alcohol uses, like we have seen 50% of tobacco users and 1/3 of them are male alcohol users. And if we see in this region, we have a shortage of tertiary care. Imagine in the entire state, we have only one cancer center. So most of the patients, they rely on to take treatment from the outside the state, which will cost them more. And also call for better access to affordable healthcare services. And as we all know that cancer has a high out-of-pocket expenditure among all the diseases, profoundly impact on the patient and the family members. So this is the Northeast region of India, which is border to Bangladesh, China, and Myanmar. So the area which I conducted my study is in Meghalaya, which has the highest number of tribal population. So the higher medical deaths and bankruptcy rates in cancer patient compared to any other diseases. And most of the patient there, they have a mortgaging, borrowing of money, selling of assets to manage healthcare costs in the low and low income countries. And apart from that, I think in the morning we have heard about the health insurance scheme, what we have in India, which is also considered as the biggest health insurance. And which was started in the year 2018 to which helps the patient covering the cancer treatment into 28,000 plus empaneled hospital. Whereas in the Northeast region in Meghalaya state, we have a different health insurance scheme called as a Meghalaya Health Insurance Scheme, which was launched in the year 2012 to reduce the out-of-pocket expenditure and also to ensure the universal health coverage for every family in the state. So the main objective of the study is to investigate the economic burden of cancer on patients which are undergoing treatment at Civil Hospital, Shillong, which is in Meghalaya, India. Moving on to the methodology, this is a hospital-based cross-sectional study which is located in the Civil Hospital, Shillong, which is considered as the largest public hospital for cancer care in Meghalaya. We have interviewed around 320 cancer patients, including head and neck cancer, gastrointestinal cancer, and respiratory cancer. Why this cancer? Because this is the top 5 cancer which is happening in the state. And we have chosen a purposive sampling method for the study. And we have got ethical clearance from the university as well as from the study site. And this study we have registered under the clinical trials registry in India. And the study population here, like I've already mentioned, the head, neck, gastrointestinal, and also the respiratory thoracic cancer, including from the stage 1 to stage 4. And the patient selection criteria were identified from the hospital registry with the permission from the higher authorities. The study tool, here we use a semi-structure which was validated by an expert, and we have categorized the question into 2 parts. The first part is based on the demographics, socioeconomic, and the cancer diagnosis. Whereas in the second part, we have the out-of-pocket expenditure related to cancer, which include the medical, non-medical, and the indirect cost. And for the cost calculation, we have the out-of-pocket expenditure definition, which include all the expenses of medical, non-medical related to cancer in the last 1 year. For the direct medical costs, which include the diagnostic, hospital stay, chemotherapy, surgery, etc. Whereas in the direct non-medical costs, which includes transportation, lodging, and food, as well as the indirect costs, which includes loss of income for patient and caregiver. So for the currency conversion is 1 INR equal to 83.25 USD. And for the data analysis, we have used the Jamui version 2.3. And for the analysis tool, we have used the generalized linear models for the out-of-pocket expenditure and the statistical significant if P is less than 0.5. Moving on to results. So this is a table which shows that majority of the patients are male and they are married and they belong to the age group of 56 to 65 years, and majority of them are Christian, and majority of them, they reside in rural area. They have a nuclear family and the family size is more than 4. And here we have used the Kuposwamy scale, which is a scale which is mainly used in Indian study, which will help to assess the socio-economic status of the family members. So we have seen that most of them belong to the upper, lower 4 class. And types of insurance which was used here, as I've already mentioned, is a Meghalaya health insurance scheme. So for the table 2, based on the cancer treatment, the patient perceived that it is affordable because due to availability of the Meghalaya health insurance schemes, and the source of expenditure, apart from them using the MHIS, they use family saving, borrowings, and also sales of assets. And the type of cancer here, majority of them are from the digestive and gastrointestinal cancer, followed by head and neck, and the respiratory and thoracic cancer. So the table 3, which shows that the total costs and the components. So we have categorized into 3 components here. The first one is the direct cost. The second one is the non-direct non-medical cost. And the third one is the indirect cost. So here we have seen that the median cost for the total direct cost is 42,000, which is in Indian rupees. And for the average non-medical cost is 3,000 rupees. Whereas for the indirect cost, we have seen the median cost is 800 rupees. And if we calculate the total of both A, B, and C, it comes up to 45,950 rupees. And the table 3, which shows that the factor which associated with the out-of-pocket expenditure by the cancer patient, here we have seen that the family who belong in the upper middle class, which has higher out-of-pocket expenditure as compared to the other classes, whereas the patient who visited monthly or monthly twice or thrice have more out-of-pocket expenditure as compared to the other class. Furthermore, a patient who doesn't have the health insurance scheme from the health insurance scheme end up paying more out of pocket as compared to the other. And the duration of illness, the patient who have less than 3 months have the higher out-of-pocket expenditure, and the patient which stage 4 cancer have the higher out-of-pocket expenditure as compared to the other. Also here, patient who receive treatment from the private, patient who travel via private transportation end up paying more as compared to the patient who travel by public transportation. And most of the patient, they rely on the family savings, borrowing, as well as the MHIS for the cancer treatment. Discussion, 82.2% perceive that cancer treatment has financially feasible due to available of Meghalaya health insurance scheme. And the similar study, which aligns with a study, conducted among patients, which sheds a light to the crucial role of health insurance in mitigate the out-of-pocket expenditure. So the frequency of hospital visits were also associated to higher out-of-pocket expenditure, particularly notably in the patient with monthly hospital visits, consistent with the study which is conducted in the south region of India. And also the private transportation for hospital visits results in higher out-of-pocket expenditure, aligning with the finding which underscore that the transportation as a substantial component for indirect costs. And the median total out-of-pocket expenditure, Indian rupees, is 45,950, which is lower than the range reported in the south region of India. And the median direct medical cost was 42,000. This finding also aligned with the study reporting in the average out-of-pocket expenditure in India, which is 50,000 rupees for the cancer patient in Trivandrum. And also among all the direct medical costs, the median investigation cost was highest, which is 3,000 rupees, which is also aligned with a similar study conducted in Hyderabad. And the median direct non-medical cost was 3,000 rupees. The median travel cost was 600 rupees. And the median indirect cost was 800 rupees, which has a similar survey in Pondicherry reported that the median indirect cost of 250 rupees. So the strength of the study, we have a robust sample size of 320 cancer patients, which provide a comprehensive data for the analysis. And we have a diverse demographic representation. And we have the critical insights for the study, and also we have the comparative analysis. And the limitation for the study is self-reported data. Most of the patient, since we don't have the record of all the patients who come to the public hospital, so we have a self-reported data, and maybe on specific cancer stages. If we look at the data, we have seen that most of the patients are not aware about the stage of the cancer, and it could be underreported indirect cost. So we have seen here, it's financially the patient who live in the northeast region of India, they have faced a lot of challenges to take treatment. And also most of them, they rely on the personal savings. So recommendation to expand the MHIS coverage and also subsidize on the non-medical expenses, strengthen the rural health infrastructure, promote early detection and telemedicine, adopt universal health coverage, and targeted support for vulnerable groups. These are a few of my references. Thank you.